This is my capstone presentation for Nurse 490. My name is Brantley Lannon, and I chose my topic because I am currently a labor and delivery nurse. So, introduction: the impact of skin-to-skin contact after birth on neonatal vital signs in preterm newborns in labor and delivery units with limited skin-to-skin contact. Workplace problem: preterm infants aren't getting skin-to-skin, and it affects their health outcomes. So, the setting is labor and delivery units. Workplace population is preterm infants, and that's an infant that was born for 37 weeks. In the definition of the workplace problem, a baby born preterm can have health issues such as hypothermia, feeding problems, anemia, respiratory distress, jaundice, sepsis, patient ductus arteriosus, and retinopathy, per the Cleveland Clinic 2024. So the problem statement: current workplace practice at Greene County General Hospital is to place the infant skin to skin with a parent, and then we dry and stimulate the baby. That doesn't always happen. Some nurses like to take the baby over the warmer instead of keeping baby skin to skin with a parent. Current data: the most current I have is 2023 and 2024. In 2023, there's 50.08% of infants that perform skin to skin with a parent for 60 minutes or greater. And in 2024, it was 65.25% per Greene County General Hospital 2024. Even though the percentage went up in 2024, there's still room for improvement because we need to be reaching 100%. So there's plenty of room for improvement. Problem statement continued. So negative outcomes related to the problem, which is lack of skin to skin. The preterm infant can become hypothermic, which is low temperature. They can have hypoglycemia, low blood sugar, and they can have irregular breathing. And this is all per the Cleveland Clinic of 2024. In the photo, you can see that the baby is having retractions, so that goes with irregular breathing. So my PICO question is: in preterm newborns born in the labor and delivery unit, how does skin-to-skin contact with a parent compared to no skin-to-skin contact affect neonatal vital signs? And then how did I pick these studies for my PICO question? Basically, I looked at studies that had the same population, preterm newborns, intervention, which is skin-to-skin, and compared that to those for infants that didn't have skin-to-skin contact and what the outcome was. Analysis of the research introduced. So basically in this part, I evaluated all three studies, and all three of my studies showed a significance of skin-to-skin contact on the preterm's health outcomes, especially their vital signs. And in all three studies, intervention consisted of skin-to-skin contact. Some of them, the time they performed skin-to-skin varied, but regardless, baby was placed on a parent's chest in just a hat and diaper. In Palvashine et al. 2023, Vogue et al. 2021, and Ramdon et al. 2025 were the authors of my studies. So my first study by Palvashine, the problem in the study was many preterm infants endure numerous painful procedures, general pain and discomfort while separated from mothers during the first few days of life, which can result in vital sign disturbances such as heart rate variability, desaturation, apnea, arterial hypertension, and intracranial pressure fluctuations. So this study was conducted in a level 3 NICU regional perinatal center. I couldn't figure out where it was exactly located because there are some different ones. And the intervention in this study was the preterm infant was placed skin to skin with the mother on the 4th through the 10th day of preterm's life. They had to have a minimum of 60 minutes of skin to skin, and they had to do 2 consecutive days of the skin to skin contact. 140 preterm infants were the size of this study. So pre-intervention, ESSEL dual infranuclear neonatal pain and discomfort scale, which is the Eden score, and labs were looked at pre-intervention. The Eden score, if there was a 6, it showed that the preterm was in a lot of pain, and the labs were collected through urine and saliva. So that's what was conducted in the pre-intervention time. Then the intervention happened, which was skin-to-skin contact between the preterm and a parent. And then post-intervention, they got labs, the same labs that they drew pre-intervention. They got those immediately after skin-to-skin was complete, and then they also re-got labs 2 hours after the time that skin-to-skin was completed. The data collection tools was the Eden score in labs. So the Eden score, like I said, if it had a level of 6, then they knew the infant was in a lot of pain. So after the post-intervention, the levels were less than 6 with the p-value of 0.005, dopamine levels of p less than 0.001, endorphin levels p equals 0.009, serotonin levels p equals 0.011, and this is all per Palvashine's study. And the dopamine, endorphin, and serotonin levels, those just help show that the infant's pain level and that they feel better. The second study was performed by Vogue et al. 2021. So their problem, they conducted this study with the intent to examine kangaroo and father care, which is also known as skin-to-skin contact, impact on prenatal infants' vital signs in the NICU. This took place in a level 3 NICU at Northwestern Medicine Prentice Women's Hospital in Chicago, Illinois. And the intervention consisted of skin-to-skin contact that lasted 90 minutes for 2 consecutive days. The size was 15 preterm infants and 30 parents were involved. So pre-intervention or pre-kangaroo care, it was 60 minutes before the skin-to-skin started. And in this study, they placed biosensors on the infant so they could collect data while skin-to-skin was being performed. In the pre-intervention, they collected this data. The intervention was skin-to-skin contact with the parent. The baby had a diaper and a hat on, and it lasted for at least 90 minutes. So post-intervention, it started once the infant was swaddled and the biosensors were removed for 45 minutes. So in that time, data was collected. So data collection tools were the media collector bedside data collection. That's what the biosensors were monitoring. So their heart rate, their respirations, and their SpO2, which is their oxygen saturation. The PhysioNet cardiovascular toolbox. This looked at their heart rate variability and periodic breathing and / apnea and respiratory waveforms. So improvements for all heart rate variability metrics was shown post-intervention, p less than 0.05. And then during kangaroo care, there's a decreased amount of periodic breathing observed by those who are collecting the data. So that shows an improvement of skin-to-skin contact with the newborn. The third study was Ramda et al. 2025. The problem in this study, so they evaluated nurse-led implications of kangaroo mother care for preterms with respiratory distress syndrome, since RDS remains one of the leading causes of mortality in preterm infants. This took place in Tanta, Egypt, across 4 NICUs. The intervention was kangaroo mother care, or also known as skin-to-skin contact. In this study, there was 240 preterm infants. The control group had 120 preterm infants that just got standard NICU care, so they weren't regulating that skin-to-skin contact. It was just standard care. They might be in an incubator, and staff just took care of these patients. There's 4 sessions where they went over policies with the preterm's parents. They encouraged daily infant care by the parents, like giving them baths and daily feeding. They did educate on safe care. And then in the last session, data was collected. And in the intervention group, they also had 120 preterm infants, which had 4 sessions. Education was provided, skin-to-skin support was provided by the staff, and final measurements were taken with the collection tools in the final session. Data collection tools were the Silverman-Anderson Respiratory Severity Scale. This looked at respiratory distress, and it had a result of p less than 0.001. The World Health Organization Kangaroo Mother Care Assessment Tool, and this measured the duration of skin-to-skin contact and adherence to kangaroo mother care techniques, which it showed a p-value of less than 0.001 at the end of the study. post-intervention. In neonatal morbidity, nosocomial infection outcomes in hospital course based on MAT showed temperature stability with a mean difference of 2.6 days, which is p less than 0.001, earlier than the controlled group temperature stability. So this shows that the intervention helped with temperature stability. So the proposed intervention is skin-to-skin contact with a parent for all these studies. They all did skin-to-skin contact. So applied to a workplace, we need to make sure we're educating staff on the importance and why we should be doing skin-to-skin. We need someone to help implement a policy, that way all staff is doing it. Individual responsibility for implementing a skin-to-skin contact. So like we have 2 nurses and one like catches baby, so that nurse would be the one responsible to implement skin-to-skin. And we need to educate the parents why skin-to-skin contact is so important. Theoretical framework. I picked Jean Watson's contribution to nursing theory, philosophy, and science of caring. And her philosophy was the importance of human connection and holistic care in promoting healing and well-being by Peptrin 2023. Skin-to-skin contact can promote healing, and nurses can provide like a positive environment which can help parents have a well-trusted relationship. And this supports my PICO because it just emphasizes the power of human connection, so that skin-to-skin contact between the preterm infant and the parent helps promote patient growth, which it does because the studies show that skin-to-skin helps neonatal outcomes. Advocating for change. The change model is plan, do, study, act, plan. So a team is going to find a specific problem in an area that needs improvement and make a detailed plan to address it. Do, they're going to use plans and put this into action. Study, a team's going to review and analyze the data collected to assess the effectiveness or if there was barriers when the intervention was implemented. Act, determine whether new plans produce effective outcomes. And then the evaluation method, we would just do pre and post intervention measurements. So we would get vital signs such as temperature, respiration, oxygenation before and after skin-to-skin was incorporated. That way we can see if the vital signs are better. Advocating for change. Barriers for implementation, a lack of parent and or knowledge. So the nurse may not have enough experience to know that skin-to-skin is beneficial, so they may not implement it, or a parent may not know the benefits and they're scared and they don't know how to perform skin-to-skin, but they're scared and they don't want to ask. And then nurse resistance to change. Some nurses have worked on the OB unit for 10 years, so they may not want to implement a change because it's going to interrupt their daily routines. Advocates for implementation. Nurses who are caring for the newborn, they need to be having conversations and educating parents of why skin-to-skin is important before the baby's born. And then the OB nurse manager, she's the one that can educate all staff, and she can also see and track how well we're doing skin-to-skin to tell us if we need to implement it better. Implications of implementing the PICO intervention. Positive impacts on patient-centered care, promotes parent-infant bonding involved in newborn's care. Their care can be more individualized and the nurse can answer questions the parents have. Positive impact on culturally centered care, respecting and supporting the family's unique cultural practices, preferences. Some parents may want the baby to be wiped off before placing skin-to-skin, which that can help us have better culturally centered care by following the parents' wishes. Ethical implications, the nurse must establish a trusting relationship and advocate for right, health, and safety of the recipients of nursing care. Legal implications, a newborn fall, the one implicating skin-to-skin needs to ensure safety at all times. Positive impact on healthcare team. It can promote a positive work environment because not everyone's stressed since the preterm's vital signs aren't stable. And then potentially negative impact on healthcare team, increased stress resulting from disruption to their usual workflow care. People could just be stressed because they don't want to do something new or they're unsure of how to. Conclusion, So the focus of this was how skin-to-skin contact between preterm newborns and a parent influences neonatal vital signs. The three studies, Palvis-Shine et al. 2023, Ramdad et al. 2025, and Volk et al. 2021, all support that skin-to-skin contact promotes neonatal vital signs. Framework, human touch and caring interaction. Jean Watson's framework helps it. The PICO goes with her theory because human touch is helping the neonates' health vital signs. The change model was the PDSA. In implementation, it's possibly going to help the healthcare team and preterm outcomes. Questions and answers. References.